The topic I wanted to talk about this week on the Weekly Peak is something called plantar fasciitis. And the reason I want to talk about this is I have a lot of patients that suffer from this condition, but as I was researching information or places they could go to find more information, I came across a lot of misinformation, as is usually the case with any chronic illness or chronic disability. Anyway, so as I was doing some research, I came across some information on the internet and on YouTube giving advice on how to diagnose, treat, and deal with this common problem. Plantar fasciitis affects more than 2 million people in the United States every day, all the time. And in the videos I was watching, the misinformation is the name, plantar fasciitis. So itis would infer inflammation. Inflammation generally happens with an acute injury or trauma, such as a bruise, a sprain, a strain, those types of things. The thing about inflammation is it follows a very predictable pattern and usually lasts from the acute phase to the healing phase about 3 weeks. So if you truly have an itis meaning inflammatory response, it should be done in about 3 weeks. So pain or disability that goes on for more than 3 weeks, and would say at a long time 6 weeks, is no longer itis. In fact, the term is osis. So in the case of plantar fasciitis, if you've been suffering with this or dealing with this for more than 3 to 6 weeks, it's now an osis, which means it's a non-inflammatory state. Hence, treatments that generally respond well to anti-inflammatories are not going to be helpful in this condition. In fact, if you're taking or applying some sort of anti-inflammatory, you're probably actually slowing the healing process, secondary to inflammation being a good thing in acute injuries. So we'll get into more of that later, but I wanted to introduce this term osis to you, and it would apply to anytime you have a connective tissue pain lasting more than 3 to 6 weeks is going to be an osis. So the first misnomer or problem with the diagnosis that we're working with is we don't treat them the same. An itis and an osis are treated differently. In fact, very, very differently. In the case of osis, we want to start an inflammatory response to get your body to recognize the fact that it needs to heal. Because once it's achieved an osis, your body is actually no longer aware of the problem and isn't doing a lot to treat it. So the next thing I'd like to talk about is anatomy. This is a person's left foot. And I'll try to hold it where we can see it. But anyway, if I want to look at the plantar fascia, I'm going to rotate this foot just a little bit. So we're kind of looking at the bottom of the foot from an oblique angle. But right here is the insertion of the plantar fascia. If I touch it, I can usually get it to turn blue. So that right there represents the plantar fascia. In this case, it's sometimes referred to as a plantar aponeurosis, meaning that it's like fascia, but it's thickened. It's thicker than regular fascia, but not quite as thick as a ligament type thing, but nonetheless is very, very strong. In the case of plantar fasciitis, this is usually the region that's affected. It's the most proximal end of the plantar fascia. So the problem with this is multifactorial, in that plantar fasciitis, for the most part, is diagnosed clinically by palpating this region right there. And if you have medial heel pain, so heel pain on your calcaneus or your heel, and it's somewhat to the inside of your heel, this is the most common place for plantar fasciitis to occur. Remembering that plantar fasciitis is generally a 3 to 6 week course and is better by then. If it moves past that, it's called plantar fasciosis. In the case of plantar fasciosis, what happens is you have microtrauma to this region right here in the fascia, which leads to what's called a longitudinal split tear. So if you can, or the possibility of a longitudinal split tear. So if you can imagine a rope and you fray the rope, basically. You don't snap it or break it in half, but you fray it. And in the case of most athletes or most professionals or most workers, you start having a pain and then you don't change anything to do with your lifestyle. So the pain goes on and on and on, and it doesn't really change. A little shot of what I'm looking at. And apparently the mailman comes up here. So anyway, I'll leave my rock up here with the rest. Get a good look at that. Another peak down. It's almost 5. I started at 9:30. I've had a couple thoughts. The first of which, and I mentioned a little bit, is as physicians, we hear a term, especially in diagnostic and interventional procedures. The procedure or the imaging modality is user dependent or operator dependent, which is a limitation of most studies, because how do you reproduce a person? So there is an importance to selecting a practitioner, a physician that you feel comfortable with and you feel whose skills are appropriate for the procedures being performed. So that user dependence or that operator dependence is a real thing, unfortunately, and every physician varies, and I'm sometimes shocked that people do as well as they do with their procedures that they receive, as you consider any future procedures that you may be participating in. And also, I'd encourage you with that notion in mind, if you go to a practitioner and you don't like them or you don't seem to click, go to another one. Don't give up on your problem. Your problem is probably fixable or resolvable in the right hands, but it does require a little bit of effort to keep searching out that person that you have a good association with that can help you along your way. I had one more thought concerning injections into the plantar fascia or thereabouts. Generally speaking, if you do participate in a steroid injection into the plantar fascia, the most efficacious or the best place, the longest lasting effect would be if you put the injection just deep to the plantar fascia as it inserts onto the heel or the calcaneus. And the reason for this is if the plantar fascia is compressing that nerve, you get like almost a 2-for-1 effect where you can decrease the swelling in the nerve and at the same time decrease the pain in the plantar fascia from that single injection. The problem with that injection is it's virtually impossible to know whether you're there or not without image guidance. But there is evidence to suggest that placement of the steroid, if you end up going that route. I've had a good time hiking to the peak of Maple Mountain today. I didn't know if I was going to get there at times, so I maybe overshot what I'm capable of at this point, but I'm on my way down now, so things are going well. But I appreciate you tuning into this and hopefully have answered some questions. And if you have any other questions, let me know. Thank you, and I will see you next week.